Thank you. Thank you very much for the opportunity. Thank you, Ben, Daphne, Gabriel. It's a real pleasure to be here sharing with you what we're doing at the Montreal Children's Hospital. The project name is Smart Hospital, but we're pretty much talking about the Smart NICU project today. I have nothing to disclose. Everything I'm going to be showing, it's funded by the Montreal Children's Foundation. There is no interference from any industry or any company. So as I said, we are funded by the Montreal Children's with some major donors. So I think this picture can tell you the influence of technology in neonatal intensive care. On your left side is the NICU in the 80s. On the right side in the NICU in the 2020s. I'm not going to say to you, but I started with the NICU in the left side. I even had that ventilator. But let's just skip that. So as you can see, technology has really helped in the survival and good quality survival of a lot of babies compared to 40 years ago. But when technology comes, you need to be aware that you have to introduce technology very carefully. So when we got the project, the first thing I came across this paper from Finland when they interview a few parents in the NICU there. They came up with a few recommendations. Modern technology has an important role in neonatal intensive care, but it can also cause fear and anxiety on parents. So this is the book from Fabiana Bacchini. She is the CEO of the Premature Foundation, Canadian Premature Babies Foundation, and a mother of an ex-preemie in the NICU. And when I was reading the book, one of the first things she says, she was very happy to watch with gratitude all the technology that was keeping her baby alive. But if you keep reading the book, a few pages later, she says, I did not see a baby when I walked into the unit. I just saw wires, monitors, and a breathing machine. And I remember holding my breath, fearing that any movement I made would disconnect one of the machines or the monitors or the wires that was keeping the baby alive. And the nurse had to teach me to take care of the baby without pulling any of the wires that I was very afraid of. And going back into the Finnish paper, they recommend the parents' experience should be considered in developing devices. We took that very seriously. You need to have special attention to the appearance and to the audible signs and alarms of the equipment. And more studies are done, especially when you are coming with new technology and getting the challenge to change an NICU or hospital into what we call a smart hospital. So I've been practicing neonatology for a while, and I never realized why the monitors are beside the babies until I got into this study. It's because they have wires and cables. That's why you need to put them on the top of the incubator, alarming, and being very difficult for the parents to move the baby. This is the mom in the NICU. She was holding her baby, and you see this long cable coming from the wall on the monitor, and while she was trying to walk on the room with her baby. And this is a baby in our NICU that when I was on call, you can see the wires tangling around the hand. So we did some quick survey with nurses in our unit, how much of your time during a shift you have to take care of the wires and the cables. And it varies between 10 to 15% of my time in the 12 hours. So this is a study done in Cambridge, England. They interview parents and they interview healthcare professionals, 6 parents and 7 nurses, about wires and cables. And this is what one of the moms said. There were more wires than him. It took ages, at least about a month, for the anxiety about the wires to calm down. And in summary, the parents in that study said that they had feelings of sadness, shock, and fear by seeing their babies in the incubator hooked to wires and cables. They believed that not having the wires would help in the skin-skin contact. And the parents also felt the wires were uncomfortable against their skin. Healthcare professionals also said a few things. Like I said, trying to untangling the wires can increase the need to handle the baby all the time, and we many times would like to have optimal handling or minimal handling of these babies. There's always a risk of pressure ulcers. Our nurses are very good, so we don't see that. But in other places, this happens. And not often, but sometimes the nurse wants to put the baby in some position, but the wires and the cables don't allow them to put in the position they want. So we did a survey in our unit on 25 parents from 24 babies. And we intentionally interviewed parents that have been in the NICU at least 3 weeks. And there is a overall dissatisfaction from them with the current wired monitoring system, and some willingness to move wireless if that's available, with a lot of things I'm gonna show you here. So we also, when we talked to the parents there, we did some videos. We have done more than 30 interviews by now.
Nathan was born at 27 weeks gestation. So he was 820 grams. So it was a very, very small baby.
It was quite traumatic to see him with all the wires, all the monitors. Because some of the challenges with all these wires is handling the baby.
Prendre les bébés avec les fils, c'est très stressant.
Chaque fois, il faut déconnecter, reconnecter. Les machines, quand elles sont déconnectées, nécessairement, ils envoient une alarme. Même s'ils sont très petits, ils sont assez sensibles à tous ces éléments stresseurs-là.
Take him out of the bed, they drag on the floor, then they end up in his bed, and it'll touch his hands, it'll touch his mouth, and trying to make sure the wires don't pull on his skin, because all this is connected to him, so you don't want to hurt him.
And when you go globally, believe me, the situation is way worse. So I go a lot to South America to give teaching, and these pictures I took with authorization in South America. So you can see they don't have the sensors we have for neonates. They put adult sensors on the chest of the babies. Because of that, there is a lot of skin lesions. And in some places in Colombia, for example, there's no monitoring at all. Because it's expensive, it's too big, and if they put the adult one, just peels the skin of the babies. So one of the questions in the project, they say, can we improve the ability to monitor vital signs in the NICU? Can we go without wires and cables? Well, we need to have the technology for that, to make the sensors smaller. So in the same paper from Cambridge, they asked parents and nurses, what do you think about wireless technology? And this is what they said. Maybe it's going to be more comfortable. Maybe it's going to reduce parental anxiety, better interaction, easier and more comfortable also for kangaroo care, and for sure beneficial for transport. This is the results of 1,100 responses from international survey we have done with physicians, nurses, and respiratory therapists and physiotherapists. Was presented at PAS, and the red bar toward the wireless technology, and in the x-axis, as you move to the left, it's very positive. So the attitude is very positive to a movement towards wireless technology from healthcare professionals as well. So now the question is it available? Because you may want to have it, but it's not available. So we did a systematic review, a white paper review, a scoping review. We basically searched for a year. And we came up, the one that we liked the most was these sensors that were developed at Northwestern University here in the United States in Chicago from John Rogers' lab. First paper was published in Science. The second one that you can see here in Nature Medicine. So we contacted them. Initially, they didn't want to talk to us, but then we insisted, and then they started to do some collaboration. They developed wireless sensors, and I have to say, these wireless sensors were not developed for neonates, was developed for adults. But one big advantage is that he's the masters of flexible bioelectronics. And flexible bioelectronics is going to pretty much change the way we do electronics because you can flex the sensor in conformity with the body shape. The other thing is that, you see in the chest sensor, you can have several vital signs in one device instead of putting multiple sensors in the patient. So we tried, so we talked to them, and then we decided, well, we need to see how it works, and can we do some studies to see how this is going to apply on babies.
First major objective of what we're trying to do is to replace the wires with wireless connections. So what we have here is not only the sensor, but the amplifier and things which sample the data. This is a transducer which will go on the chest of the baby. And it will record ECG, breathing, and temperature. And then this one, which goes on the limb of the baby, will record oxygen saturation and a signal called the PPG. The only thing that needs to be attached to the baby are these two devices, and everything else will go wirelessly to the baby by way of a Bluetooth connection. And in the further term, we could think about home use and whatnot, where we can essentially send babies home and monitor them.
C'est le bon moment et même au-delà du bon moment pour justement transformer l'hôpital en système sans fil et en système plus intelligent.
And we are very grateful to the donors to trust that we can do and perhaps establish in the near future the first smart hospital, pediatric hospital in Canada. So they ask parents, what are the possible problems and concerns you think you may have with that? Well, those sensors need to be reliable, good quality data, make sure the right sensor connects to the right monitor, about heating, battery life, size, and the weight of the sensors. I can tell you it's very light. The battery life is 48 to 72 hours. There's no heating in the sensors I just showed you. So as you know, assessment of new technologies not only needs to make sense, but also needs to be checked. So according to the National Academy of Science and the Institute of Medicine, new technology must be carefully evaluated in terms of added value and limitations. So a big example is pulse oximetry. For those that don't know, it started in the early 70s. It took 5 years to be commercialized. And then 15 years to become the fifth vital sign. We had to do several studies to show the benefits, and we found out a lot of things that related to ambient light, skin pigmentation, poor perfusion, hypothermia, everything that can affect the signal. So we've designed a study where we put the wired sensors and the wireless sensors in the babies at the same time inside the NICU, in real life. So basically, these babies were monitored 4 days a week, 8 hours a day, 32 hours each baby, and normal life during the monitoring of these patients. And we collected the wired values and the wireless values at the same time, and we compare. Here, presenting to you the results of the heart rate. It's absolutely identical. It's still not perfect because there are issues with the respiratory rate, and there are issues with Bluetooth connectivity. So this moment we fed back to the company and told the company, you should change. Number one was too rigid, it needs to be more flexible. So they changed and they made these kind of sensors. These are dedicated to neonates. So they moved the antenna to the right side to see if the antenna on the right side of the baby will have less problems. They changed the adhesive, and it's very flexible and very soft on the skin. And that's how it looks like in a patient. And of course, the size is still not ideal size for very small babies. We're working on another sensor for less than 1,000 gram babies. And so we've done another study with 25 babies in the real life NICU. And those are the results in the first 21 babies, and it's identical for their heart rate. So the Smart Hospital projects and the NICU projects is not just about wireless technology. We want to change monitoring of vital signs in the NICU, but also we want to see monitoring of vital signs in the delivery room. We want to develop a family-friendly dashboard. I'll show you a smart dashboard for healthcare professionals. The project grew. We're developing machine learning that has been demonstrated by the speakers for extubation failure, for example. We developed and we are testing new physiological sensors I'll quickly go over. Now, we want to know how can we improve CPAP delivery. We want to know how can we better monitor phototherapy, improve detection and classification of apneas in the NICU. And one of the major goals is to provide training for masters, PhD, and students from experimental medicine and biomedical engineering. So going for number 2, monitoring the delivery room. This is a survey done and published in PEDS Research a few years ago in UK, and almost 80% of the physicians interviewed said we need to improve monitoring the delivery room, and wireless technology was ranked as number 3. So we developed the advanced wireless sensors for neonatal care in the delivery room, the award prospective study. We did a simulation study first. As you can see here, what we want to do, so there's no point to introduce a technology if it's more complex to place this technology in the patient. So we would like to evaluate how quick can you put the sensors and the complexity of hands movement of the people in the resuscitation. So this is a simulation, resuscitation simulation. A study we have done 120 simulations and presented at PAS. On the left side, it's the healthcare professionals putting the wired system, and then you see putting the wireless system. So this is what we found. So we measure the speed of sensor placement, the effort to place, and the smoothness of the hand's movement. So basically, there was an IMU on the wrist of every healthcare professional that could give us a measurement of effort and smoothness with complexity. The video cameras gave us the time between holding the sensor and putting the sensor on the patient and then removing the hand. So as you can see in the blue, the wireless sensors were 54% faster. It's about 7 seconds in resuscitation faster to be placed. And with 57% less effort and 30% less complex to be placed. So there are some advantages of a wireless system. The cost, a lot of people ask me this question, is estimated to be 10 times less than what we have now. It's a tablet, and basically the sensor is cheaper than a Fitbit. And it can be reused for a year. And it comes with a charger, and you can just recharge the sensor and use it again, clean and use it again. Big advantage for countries where there is problems with electricity and problems in biotechnology, like I said to you, in South America and Africa. It does not require installation. This big monitor is very difficult. Just at the Montreal Children's, we changed the monitor. It took 6 months to do the installation of everything. It can run without power for 48, 72 hours. So if a hospital in Africa goes out of power for 24 hours and the sensors are charged and the tablet is charged, they continue to monitor these patients. They're smaller, they are portable, they're eco-friendly because they're not disposable. And it's just an example. This is one NICU in the northeast of Brazil. When I walked there a year and a half ago, the first one is the resus. There's no monitoring at all. And the other 5 different monitors in 5 different patients in the NICU. because they buy whatever is possible to buy and it's available. So with that, we want to move to the advanced wireless, the award study, a prospective multi-center study. We got funds for that. We're going to apply the sensors, wireless and wired, after vaginal delivery and C-section. Of course, we're going to initiate in normal babies, not in resuscitation, to see if it works. And that's going to be a study that will have sites in high, middle, and low-income countries at the same time. So there's a center in Canada, 2 centers in South America, and 2 centers in Africa. Well, the project is always worried about environment, noise, and information in the NICU. Our NICU is a single patient NICU, but if you go around, the NICUs are extremely busy on open or semi-open bays. So what we envision is that this is what we have now. We have the mom and the incubator, and the monitor is there, and the parents keep seeing all these tracings and monitor and numbers and alarms and etc. So what we want to do is to develop a monitor that's a family-friendly monitor inside the room, and the healthcare professionals receive the medical information outside of the room in a tablet, in a cell phone, or in a computer outside. So basically make the room environment more friendly for the family. So we interviewed a lot of parents for that, and then got consultation with many nurses with expertise on that. And we're coming up with this smart dashboard. It's ready. The first prototype is ready. Basically, it's a monitor. It's a big one that has 2 views. You just touch and change to the parent's view, or touch, changes to the healthcare professional view. And this is the parent's view. So that's the information parents told us they would like to see in the monitor, instead of the ECG tracing or the oxygen saturation tracing. There's a lot of things there. It's very interactive. It's a touch screen, and they can enter a lot of information, input activity of the baby, what the baby like, and etc. Healthcare professional walks into the room, touch the team screen, and then changes to that, which is what we see every day. Healthcare professional walks outside of the room, a few minutes later, flip back automatically to the parent's view. And you can put as many patients as you want into that screen. Here we just put 4 patients in the screen, so the nurse can see many rooms at the same time. There's a plan and milestone, among many other things. There's a glossary about neonatal problems and etc. But as you can see here, every baby has a head ultrasound to be done, has an appointment, so it's all there. We're also looking to new technologies. We're developing acoustic sensors, wireless, small, to capture heart sounds, air sounds from the lungs, and bowel sounds. So for example, the respiratory and bowel sounds, we just did a study with Northwestern that was published last year. And this is the bowel sound. We put 2 sensors and fed the babies, and you can see that the bowel sounds go up after you feed, the first one here, and then goes down, and then goes up to the other one. You can transit time between one bowel sound here and the other one. It's small. Now it's even half of the size that you can see here, and it's wireless, and for 48 hours you have continuous bowel sound recording. So there are many new technologies we're looking into that, to capture the sound of the bubble sounds, the incubator, the cry as a vital sign. There's a wireless sensors developed to be tested. We're going to initiate in November that measure continuously the irradiance from the phototherapy, so you can have cumulative irradiance over time. And there are some other ones, like we just applied to IRB, approved to study on wireless AEG and wireless NIRS. So this is the phototherapy one. So I'd like to thank very much my team. They do most of the work. I'm here in Florida in the sun. And thank you again for the invitation.